I am Dr. Nyunt from Biliary and Pancreatic Surgery Department of Yangon Specialty Hospital. So I will now present the fluid management, what and how much. Declaration is there is nothing to disclose. Going to introduction. In 2023, 34,000 patients worldwide undergo liver transplantation annually. And perioperative outcomes have been improved much nowadays due to advancement in preoperative optimization, surgical techniques, immunosuppression, and perioperative care. Improvement in critical care technology and better knowledge in perioperative fluid management lower the perioperative morbidity and mortality. So, huge hemodynamic shift occur in the liver transplantation and is more significant in patients with cirrhosis with portal hypertension. So fluid administration is a critical component of perioperative management for liver transplant recipients. And excessive fluid infusion can lead to poor patient outcome. So when to give fluid? In preoperative fluid optimization and during intraoperative replacement and postoperative maintenance. So there's many types of fluid used in postoperative management or perioperative management. There's blood and blood products, crystalloid, colloid, and albumin. So according to the blood and blood products, is shifting to the restricted strategy, and now overall usage of blood and blood products have reduced nowadays. According to viscoelastic testing, TEG rodent is the cornerstone in perioperative usage of blood and blood products, which can be used as point of care testing. In liver transplantation, the state of coagulation changes rapidly, and it is not appropriate to perform treatment based only on test results, and it is essential to consider the clinical situations. According to crystallite, there is a many crystallite formed with 0.9% sodium, lactated ringa or ringa acetate, 5% dextrose, dextrosaline with variable strength, balanced electrolyte solutions, plasma light, normozole, and stereofundin. There is various components in various type of solutions. Now, balanced crystallite solutions developed in 1960 as an alternative and become widely used in modern era, especially in critical care and transplantation. Balanced crystallite have a sodium, potassium, and chloride content closer to that of extracellular fluid, and when given intravenously, have fewer adverse effects on acid-base balance. So balanced crystallite solution, for example, plasmalite normozole are preferred over 0.9% saline or lactated ringa, which have risks of hyperchloremic acidosis and impaired lactate clearance in liver failure patients. So this is a balanced crystallite solution. In lactated ringa, there is a lactate, and plasmalite, there is acetate gluconate, and normozole is a gluconate, stereofundin as acetate and malate. So, according to the lactate buffer solution, ringa lactate or Hartmann solution, lactate has to be metabolized in liver to bicarbonate to act as buffer. This function may be impaired until the new liver fully functions. Instead of being metabolized, lactate can accumulate and potentially increasing acid-base imbalance. Bicarbonated ringa solutions are alternatives. According to acetate buffer fluid, in this study, plasmalite is often the preferred crystallite, and less metabolic abnormalities and lower post-infusion serum concentration of chloride and lactate, so higher base excess compared with other balanced crystalloids. So, acidic buffered versus lactate buffered fluids. In this study, quantity and quality of evidence up to now is still low and no statistically different in short-term mortality, hospital or ICU length of stay. Further high-quality trials are still needed. According to acetate versus 0.9% saline, in study of acetate buffer crystallite infusate versus infusion of 0.9% saline and hemodynamic stability in patient undergoing renal transplantation, reduced need for use of catecholamine and accumulated catecholamine dose for hemodynamic support, less occurrence of arterial hypotension in perioperative period. And acetate versus 0.9% saline, plasma-like A, demonstrated superior preservation of acid-base balance compared to 0.9% normal saline, with less need for bicarbonate supplementation. While liver function outcomes were similar, the balanced solution showed a trend toward better metabolic stability, suggesting it may offer safer and more effective fluid management in liver transplantation surgery. According to synthetic colloid, there is a HES, dextran, and gelatin. Previously widely used as a plasma expander, HES is uniformly not recommended in liver transplantation due to increased risk of AKI and coagulopathy. Some centers use gelatin with low-dose albumin as a cost-effective alternative to pure albumin, though outcomes vary. According to the albumin, albumin is a key fluid across all phases of liver transplantation, with its concentration tailored according to timing, indication, and institutional protocols. Commercially available are 5%, 20%, and 25% according to region, but can be diluted depending purpose of users. Albumin could be advised in an early post-operative period of potentially prevent AKI development. The use of albumin after liver transplant is not without risk, may be associated with an increased risk of infection, bleeding, and other adverse events. The cause of albumin also the significance. So albumin versus crystalloid. 30 patients with 5% albumin solution were compared with those 27 patients who received a crystalloid solution. Sequential or organ failure assessment scores are not significantly different, and further research need to confirm these findings and fully understand the potential benefits and risks of using either type of fluid. So now how to give the fluid? One is to maintain hemodynamic stability and to assure end organ perfusion and to avoid hypovolemia and overload. For achieving these targets required a comprehensive understanding of the fluid responsiveness and judicious applications of monitoring techniques. Not only the static assessment, but also the dynamic monitoring is important. But every technique has their own limitations, and understanding the physiology and clinical monitoring is also important. According to perioperative monitoring, there is a standard perioperative monitoring such as standard anesthesia monitor for ECG, pulse oximeter, carbon dioxide temperature, and central venous pressure, arterial pressure monitoring. In advanced hemodynamic monitoring, transesophageal echocardiography, and pulmonary arterial catheter, and transpulmonary thermodilution system, PICCO and EV1000, pulse control analysis or arterial waveform device. So in fluid therapy, there is a goal-directed fluid therapy in liver transplantation. Goal-directed fluid therapy has been accepted to use in perioperative fluid administration to improve outcome. It has been widely used in perioperative care of major surgery, including liver surgery. Evidence of use of goal-directed fluid therapy in liver transplantation are still limited and due to the complex physiology in liver disease patients, such as high cardiac output, low CVP, and reduced urine output make the optimal goal. So, the optimal goal-directed therapy protocol for perioperative management of liver transplant patient has not been defined. So, major hurdle is the assessment of cardiac preload given the major hemodynamic changes in cirrhosis. Goal-directed fluid therapy was associated with an increased volume of crystalloid administered but did not alter early post-operative pulmonary or renal function when compared with standard care. According to the impact of goal-directed therapy protocol on post-operative fluid balance in patients undergoing liver transplantation is a retrospective therapy from France said reduced fluid balance and decreased requirement for mechanical ventilation and post-operative ileus durations. This is not widely accepted due to the unpredictable hemodynamics in cirrhosis and surgical phases with rapid fluid shifts, for example, anhepatic, cable clamping, and reperfusion phases. Evidence is still limited and mixed. So restricted fluid therapy with use of vasopressor instead of fluids. So eras in liver transplantation, eras for orthotopic liver transplantation is say a restricted fluid management strategy may carefully be considered during liver transplant over a more liberal one. Indirect evidence from other major surgery populations suggests that a goal-directed fluid therapy may provide better outcomes than the standard of care. Transesophageal echocardiography may be considered to target fluid therapy. So, ERAS protocol in liver transplant patients regarding the fluid therapy, monitoring during liver transplant should include invasive arterial blood pressure as well as the involvement of clinician and expertise in pulmonary artery catheter or transesophageal endocardiography. HECS is not recommended. And moderately restricted fluid regimen, especially during the dissection phase of liver transplant and maintaining mean arterial pressure beyond 60 millimeter mercury during liver transplant. Now, next strategy is a fluid restriction strategy. In the study of restricted crystalloid fluid therapy during orthotopic liver transplant surgery and its effect on respiratory and renal insufficiency in the early post-operative period is a randomized clinical trial. In randomized control trials, 67 adult liver transplant patients compared with restricted, which means 5 ml per kg per hour, versus non-restricted, more than 10 ml per kg per hour with normal saline. The restricted arm had zero pulmonary insufficiency and zero pulmonary insufficiency in post-operatively, was 15% in liver occlusions, and no increase in renal dysfunction. Creatinine is similar. So, according to the vasopressor during cable clamping, volume expansion during cable clamping is short duration but important fluid management. Vasopressor can reduce the volume of fluid loading that time since excessive fluid leads to congestion and bleeding. Restricted strategy in combination with vasopressor can maintain the hemodynamic with less complications. In the study of effect of perioperative fluid therapy on postoperative renal functions in patients receiving liver transplantation from living donors. So in this study, a retrospective observational study of 91 patients categorized patients into restrictive, moderate, and liberal regimen. Moderate fluid strategies correlate with better renal outcome, lower peak creatinine, and while liberal strategies associated with increased peak serum creatinine level. In perioperative fluid management and outcomes in adult deceased donor liver transplantation surgery, study is a moderately restricted or replacement only fluid regime is recommended. And in hypervolemia, based on absence of fluid responsiveness, elevated filling pressure and or echocardiographic finding should be avoided. In quality of evidence is moderate and grade of recommendations and weak or restriction strong for the hypervolemic avoidance. Mean arterial pressure should be maintained more than 60 to 65 millimeter mercury in all cases. So in consensus document from the Spanish Society for Liver Transplantation, moderately restricted fluid administration regime is recommended. Evidence and recommendation is C1, and the use of 6% 130.44 HES is not recommended in patients with chronic liver disease. It is recommended to maintain mean blood pressure values above 60 to 65 millimeter mercury. So in done an overview of unresolved issue in the perioperative management of liver transplant patient. So it is low CVP, less than 5 millimeter mercury can decrease intraoperative transfusion requirement, but associated with an increased risk of post-operative renal failure. High CVP, more than 10 millimeter mercury, is also linked to a greater incidence of post-operative respiratory complications, longer intensive care unit stays, and higher mortality rates. So, moderately restrictive fluid therapy approaches combined with maintaining a mean arterial pressure more than 60 to 65 millimeter mercury has been recommended to reduce blood loss during the dissection phases, and this can be achieved by maintaining a subnormal CVP between 5 to 7 millimeter mercury and administering mild to moderate doses of vasopressor. And clinical consequences typically associated with hypervolemia, such as increased blood loss, the need for transfusion, and postoperative respiratory complications, are minimized with this approach. And there is no increased risk of acute kidney failure injury. It's a Rose concept. Morbring et al. Expound the risk of fluid overload and 4 phases of fluid management, such as resuscitation, optimization, stabilization, and evacuation, Rose in septic shock. The concepts are also conducted in perioperative fluid therapy. During post of days 0 to day 1, resuscitation and optimization phase is positive fluid balance, and post of day 2 to day 6, stabilization and evacuation phase, this is a negative fluid balance. So, going to AKI and fluid balance. The trend of incidence of AKI after liver transplant is highest on day 1 to 2 is about 52.4%, likely related to the surgical stress and excessive fluid infusion. Gradually decrease on day 3 to day 7, possibly related to resolving surgical stress and fluid removal. The consistency between the trends in the incidence of AKI after liver transplant and fluid balance suggests a correlation between fluid balance and AKI in liver transplant patients. Observational data show that fluid balance more than 1 liter within 2 days post-operatively significantly increase the rates of AKI on day 2 or after liver transplant. So, for my conclusion, balanced crystallized solutions are the foundation. Acidic buffer solutions are more preferred. And use of albumin could be advised in early post-operative period, and HES is better avoided. Cold direct fluid therapy is not widely accepted now and should be tried in ERAS in liver transplantation. And modestly restrictive perioperative fluid strategies, and based on moderate level evidence and maintaining MAP between 60 and 65 millimeter mercury, and phase-specific hemodynamic targets and early post-operative fluid evacuation strategies to minimize AKI and respiratory mobility. This is it.